Aha. You see my screen or not? I don't.
No.
Yes.
No.
I don't know what. I'll try again. I don't know. It's not working.
I see it.
We can see what you see in the screen, I think.
And I don't see anything.
You have to open your presentation, maybe.
I have opened it.
Coming now.
It's very dark.
Yeah. There you go.
Yes, something is coming on the corner. Yes, okay.
And a typical cyst.
Do you see my presentation?
Yes.
Yes.
Yes. Okay. So, hello everybody. This is well, I want to have your opinion on that case because it's not completely solved. So it is a patient, a young woman, 32 old, and she is doctor in pharmacy. She's married and lives in Bordeaux. In her medical past history, there is a major event. It was gestational choriocarcinoma in 2013, treated by surgery and chemotherapy, and she recovered. She fully recovered, and the 5-year follow-up is normal. And she came at my consultation. She was asymptomatic, so with excellent general status. And came because there was a positive diagnosis of a cystic mass in the liver on ultrasonography. And well, everything was normal, the liver biology and all the blood tests. And this is the MRI. As you see, there is a cyst, a multilocular cyst in the right liver, and also 2 other cysts in segment 8 and segment 6. You have here all the MRI. Okay. So what is your diagnosis, and do you need other investigations?
May you come back on the CT?
Yes. This is the okay.
Laura, do you have serology for echinococcus?
You are very good. So, in fact, I asked for a serology, and it was so. It will be a very, very short case because it was indeed okay. I wondered if you wanted a CT scan, and this is the CT scan. And you see there is a very a slight calcification in the center of the cyst. And the PET scan that was performed showed a very slight enhancement in the major cyst, not in the other cysts. So we were concerned about her history of cholangiocarcinoma, and we performed a beta HCC, which is normal. And in fact, the alveolar echinococcus serology I systematically asked at the consultation was positive. And it was quite confusing because she didn't report any travel with some hiking in the south of France, in the Pyrenees. And our parasitology department was extremely excited with this case and asked for a very complete checkup with brain MRI, thoracic CT, and in fact, the final diagnosis was hepatic isolated alveolar echinococcus. So, what is for you the treatment?
Let me discuss about you know, it cannot come like this. It was a contamination.
I thought you it was really very astonishing, because it was not in France. There is a very, very few cases of this pathology, and particularly in my area, because it's not seen in my area. There is no endemic of Echinococcus alveoli.
As you know, it is not the dog, so it is not the dog, but usually the fox. He said she did hiking in the south.
Yes, only that, never traveled. So probably is one of the first cases of autochthon Echinococcus in our area.
A migrant fox.
Yes, but she didn't see any fox. I asked that, and it was really a systematic serology I asked for, but it was not my first diagnosis.
Okay, now we have the diagnosis.
Okay, so the problem now is the treatment of this patient, because you know that the recommendation is that you have to perform a radical surgery, like an oncological surgery, and the recommendation is to have a 2 centimeter margin to avoid recurrence. So what do you think I should do?
But Laurence, if you think that we should have 2 centimeters in this case, you will have to do a vena cava resection.
Do you think so? That is my...
Yes.
That is exactly my concern.
Yeah. How does the hilum side look?
The hilum is good. Look at that. I just show you here the CT scan. But
Yeah,
I wonder if it's useful for this young lady to resect the vena cava.
Yeah.
That
And
is...
you, yes.
Yeah.
Can you see the hepatic veins better?
And the
Because it
hepatic
looks like
vein,
at
I
least
should
the left is
resect
free.
the... In fact, I would... It's necessary here. This is the best image. And you see that it's really near the middle hepatic vein. So I should resect middle hepatic vein and vena cava. Do you think so?
I think you
Well, if you
probably,
want to be radical,
I
yes.
think only way to the radical is to you kind of transect the left lateral off and then take everything out and replace the vena cava, put the left hepatic vein onto the graft. I think that's probably
Yeah,
the way.
I think probably you can still manage to keep the left hepatic vein in the vena cava and resect it only below that, so that you cannot reconstruct the left, but still you have to clamp the vena cava for quite a prolonged time, I think.
Yeah.
Can I say something?
Oh, I'm sorry, go ahead.
I saw a few cases. Alveolar echinococcus is endemic in Lausanne, where I used to work. We had lots of cases, and we had some resection which were R1, and they were controlled by albendazole therapy lifelong. So I think if it's too risky to have a caval resection, there can be a R1 resection with lifelong albendazole treatment.
Let me just ask you, Alessandra. For example, for granulosis, we do preoperative treatment with albendazole and then postoperative treatment. Do you think this could reduce this and allow for a...
Yes.
For alveolar 2, we used to give albendazole at least two or 3 weeks before, and then for 2 years afterwards.
Okay, they recommend me to do albendazole therapy only 1 week before and not more. And they said that anyway, he had to have albendazole lifelong, even if it's R0 resection. So my consideration is that it is a right hepatectomy with a resection of the middle hepatic vein, because if you resect the vena cava, you have to resect the middle hepatic vein. So
Yes.
otherwise, it wouldn't be logical. So I performed a right embolization, a portal embolization, because look at that. It is this is the volumetry,
Yes.
and I think it's necessary to embolize because it will be a very heavy procedure. But honestly, I thought that it wouldn't be necessary to resect the vena cava because I could have a patch only and not the whole resection.
Yes. In fact, you can use, for example, a patch of falciform ligaments.
Yes.
With this effect.
Yes. I think it would be less because otherwise, if I resect the whole vena cava, I would have to reconstruct it, and for her, it's quite well. I'm not sure it's worth it.
What I just think. Sorry, Professor Bismuth.
No, Laurence. Did you study usually in this case of alveolar ectopics the arteriography? I don't know if you remember, but I described many years ago when we did work on the arteriography in liver disease. We published case of this disease with stricture of the hepatic artery. And it was the sign of the diffusion of the parasite along the hilus. And in a case like this one, where the cysts are central, there is a risk of also extension to the left of the liver. At that time, you may find some stricture, a very typical stricture in the hepatic artery, in the branch and in the hepatic artery.
Yes, but in that case, as you see, there is no relationship with the hilum. So I think it's far from the arteries. So the problem is only the venous relationship. So I know that I have to treat patients with a biliary and arterial relationship, but not like this one. So I wonder if you have the experience of that. So maybe I can conclude that I have to resect all the venous structures around this cyst.
I think Daniel Cherki has raised their hands.
Okay.
Yes, hello, sorry I came in late. I just saw the end of the presentation. I had a case a little different from that, but it was also in contact with the vena cava, and a couple of cases actually. And I presented the case to Georges Mencion, who is surgeon from Besançon, has a large experience with this disease, alveolar echinococcosis. And his conclusion was not to treat with the disease and to resect the IVC whenever there's a large contact with it.
Okay.
So I would agree with Hugo that in a case like that, and was quite similar to mine, is to resect the IVC below the level of the left hepatic vein. I believe that the entrance of the middle hepatic vein can be preserved, and replace the IVC below.
And I would say, Laurence, but perhaps you need total vascular exclusion for this.
Oh, definitely.
10
Yes,
to
of course.
20% doesn't tolerate, so you may need the venous bypass, I think, and probably if you consider whether replacing this with a graft or filling the defect, the repair time would be very different, I think, because it would take you, I don't know, 30 minutes overall, I think. What we could use here, instead of a patch of falciform, is to replace the whole IVC with a cadaveric graft, for example. That wouldn't that allow you not to use anticoagulation after
yeah.
that.
Yeah.
This is usually not immunogenic. It's not necessary to be the same blood group, so it usually works, at least for us.
Okay. Okay.
I use PTFE graft.
Yeah.
Also,
Thank
With,
you.
Yeah.
with rings, and it works well. No anticoagulation.
Yeah, I do that too. But Hugo, you use the cadaveric cryopreserved or fresh?
not cryopreserved. Not cryopreserved. We use recent cadaveric, usually less than 6 or 7 days, and no problems with that. It's
Yeah,
the experience from Oslo.
Yeah,
They
that's not
this with no problem.
allowed in US by the
It is
FDA
not.
regulation.
Okay. Thank you very much. I will do
Thank
that.
you, Laurent. Thank you.
Thank you.
So now I may present my where to find partage l'écran.
I think Laurence has to leave.
I do. Okay.
Okay.
It's done.
Where is partage l'écran?
On the bar, just this is a square
It's an
with the
arrow.
with the arrow.
Present now. Present now. It's an arrow.
Not, oh, yes. Coming? No. What is that? What is that?
You can, Mr. Bismuth, you can minimize the Zoom and open your presentation.
Minimize the Zoom.
The Zoom and open your presentation. yeah,
But what is all this?
because
This is amazing. What is that?
your presentation is behind this.
I
yeah.
cannot close nothing. There are so many. Vous êtes en train de présenter, c'est pas vrai. Alors, qu'est-ce que je fais?
So vous minimisez le zoom
Et comment je mets le zoom?
avec cette portion jaune là. Vous avez
Là,
le cercle jaune là.
Yellow circle, right?
Yes, the yellow circle,
where is the yellow circle? This one?
All the way to the top. All
the
the way
bigger
to the
one.
top.
the-
Yeah,
not
all
that
the way.
one. That
This one?
one.
Yeah, that one.
Ah,
Okay.
you see something?
Yes.
Yes.
And now you can maximize the presentation.
Yes, yes.
Okay.
It's okay. You see something?
Yes.
Yes.
This is not a presentation. This is by the injury, complicated, and complicated so far that liver transplantation is indicated. And this is a case reported by a Greek surgeon, and he said that not only he was led to do a liver transplantation, but also the patient died. Now, in my experience, all cases are very complicated by the injury are mainly due to error. So now I will present what he presents, the surgeon, and I will ask you where is the error. There could be one, there could be two, there could be three, there could be many, but I would like that to find the error. This is the presentation. I would like that some of you, Hugo, can you read the presentation slowly?
Yes. So a 36-year-old obese Caucasian woman underwent a laparoscopic cholecystectomy for symptomatic cholecystolithiasis at an outside institution. Intraoperatively, she sustained an E4 bile duct injury in conjunction with total transection of the right hepatic artery. The surgeon converted to an open laparotomy, examined the sites, placed two drains, and immediately transferred the patient to our center for further evaluation and treatment. At relaparotomy, a dearterialized right liver, as well as 7 bile duct orifices were found. A right hemiapatectomy and a Roux-en-Y drainage of the 4 left-sided bile ducts were performed. The post-operative course was complicated by bile leaks, not surprisingly. Okay.
No.
Following,
Requiring, continue, please, Hugo.
requiring reoperation and relapsing episodes of cholangitis and intrahepatic bilomas, requiring resubmissions of the patients and conservative treatment with intravenous antibiotics and percutaneous drainage procedures, respectively. She subsequently developed severe endocarditis, leading to cardiac, mitral, and aortic valves insufficiency, grades 3 and 2 respectively, demanding mechanical replacement of them. The patient developed secondary biliary cirrhosis, was listed to Eurotransplant with a model of end-stage liver disease score of 39, and underwent liver transplantation 19 months after laparoscopic cholecystectomy. Histology of the explanted liver showed 50% parenchymal necrosis, chronic cholestasis, and cirrhosis. On post-transplant day 5, she developed cardiogenic shock associated with pericardial tamponade that, despite adequate surgical drainage, progressed to multi-organ failure and death 7 days later.
Thank you, Hugo. Now, who want to speak first?
I would.
There are errors since the beginning. Where are the errors?
I think, first of all, if you don't count the bile duct injury, I don't know if you can come back. So besides the bile duct injury, I think, as you usually say, Professor Bismuth, there is no rush to go to immediate laparotomy as soon as a referral center receives the patients. And also, it is very rare for us to have an indication for a right hemiapatectomy, because most of the times, even if you don't have an artery, we have a communicating ways, especially through the hilar plate, that allow us to arterialize the right liver, and we see that often. So I think this would be my first 2 repairs.
So it's correct, Hugo. What you said is first that they said that there is a transection of the right hepatic artery. And then at laparotomy, he discovered a dearterialized right liver. This is never observed. That means to dearterialize the right liver is not enough to do a ligation of the right hepatic artery. I published a case many years ago on a patient sent to me after a bile duct injury, and the surgeon, unfortunately, don't control the hepatic artery. That means the patient was coming with bleeding. It was necessary to do laparotomy. And laparotomy, there was a lot of bile, and there was bleeding from the hepatic artery. It was indeed the right branch. And it was the hepatic artery. And I hesitate to ligate the hepatic artery, and I took it back. And as the bile duct was clearly cut, I did it. If I tell you the story, is that the patient has a nice follow-up, and I did the control 2 weeks after of the artery, and the artery was obstructed, totally obstructed. But there was a communication between the 2 livers. That means that, of course, it was useless to do that, to do the reconstruction. And I published the case, and it was called, "Is the hepatic artery necessary?" And as you know, there was a description by an anatomist, English anatomist called Michels. He described 21 ways of apport of the arterial blood to the liver. That means hepatic artery is not necessary, except in one case, the liver transplantation, or liver transplantation, full connection of the liver. I mean, there is no more arterial blood supply. But in all other settings, there is a lot, and you know that. You know, of course, the left hepatic artery, that's the artery of the diaphragm from the portal pedicle. Anatomist Michel described 21 ways of doing it. That means, coming to the first error, what I consider the first error is to consider that the liver was dearterialized with only the ligation of the right hepatic artery. Comment? Somebody comment?
No, I was just saying that we cannot hear you very well, Professor.
I'm
Perhaps
sorry.
the internet.
Aha. And now you listen better?
Yes.
Yes.
I have to. A pity you did not listen what I said.
Not entirely. Not entirely.
You heard most of it, though. Yeah.
Which part you miss?
No.
Anyway, I said what I said is the ligation of the right hepatic artery is not enough to lead to the arterialized right. That means that there was no indication, only for this reason, to do a right liver resection. And this is the first error.
I think John wanted to say something.
Yeah, so I just want to comment. When he said dearterialized, I wonder whether they meant a devascularized right liver. And seeing a lot of bowel duct injuries in my time, the few cases where we've had devascularized liver was when we had not only an arterial injury, but also a portal inflow compromised.
Yeah, I agree. I
Led to a
agree.
disaster. And
Yes.
yeah. Mm.
I agree. Yes, I agree. And, I would like to, I may speak about that, but I let this case at the end. Well, one case, but at the end I will comment on one case of liver transplantation that we performed in emergency for but this is very specific. So you said Hugo's error is what I call early repair. And of course, I agree with you, but when I describe the way of putting the pilot injury, I said that if it is acceptable to do immediate repair, if you have a clear finding of the gut, to do the repair just after. So what we call immediate repair is during surgery. It's clear. During the polycystic immediately. But if you do the repair the day after and for the 2 following weeks, this is the bad moment to do the repair. For many reasons. One, there is no dilatation of the branch. Two, there is usually inflammatory process after the polycystectomy. And this inflammation is very large, very important if there is a binding. And even if it's not the coloperitoneum, but there is a bile leak all around the hepatic pedicle. There is inflammation. So this is the worst moment. And in the report that was published, there was a lot of death at the time of the report. But there is another error. it is said that the first surgeon said, I think the first surgeon said, that his problem intraoperatively was the before is the Strasberg classification. It is my classification, the Strasberg my classification, and put inside this classification. I don't want to speak about the error of Strasberg today, but I only said that it is very difficult at time of the trauma to recognize exactly what is the level of the bile duct injury. In addition, and further, he said, the second surgeon said he found 7 bile duct orifices. How to find 7 bile duct orifices? If there was not a very high dissection. Personally, in all the study I did on biliary repair, I never observed a so large trauma on the left. In order to have 7 bile duct orifices, it is 4 on the right and 3 on the left. 7. Can you imagine to have a bile duct cutting all the bile duct? I think this description is not the description of the first surgeon. It's the dissection of the second surgeon. And for me,
J'entends plus rien.
We can't hear you.
oh, it's a pity. I have no earphone. For me, it is the maximum of the voice.
Okay.
Look,
Can
you listen now?
Yes,
Yes,
peut-être il y a une autre place où vous avez une connexion, une meilleure
Meilleure.
connexion.
Alors, attendez. Maintenant, vous m'entendez mieux?
Oui, oui, là, ça va.
Oui, je crois.
Ça va?
Mm.
Non, alors je disais simplement, I was only saying that to find 7 bile duct orifices was due to the very large dissection of the thymus. And it's not the second surgery.
Monsieur, ça n'est pas un problème de micro, c'est un problème de connexion Internet. Il faudrait que vous changiez d'endroit.
Alors, je vais me promener. Est-ce que vous entendez mieux, là?
Oui.
Là.
Un peu.
Et là.
Peut-être à côté du routeur de l'origine.
Alors, attendez. Là, c'est mieux? Est-ce qu'ici, c'est mieux?
Oui,
Oui.
Oui, apparemment.
C'est mieux, là?
oui, mais vous pouvez vous asseoir quand même.
Comment vous avez... Comment vous avez... Et là, c'est mieux? Là, c'est mieux.
Ça me rappelle.
Aïe, aïe, aïe. Aïe, le nez.
C'est pas bien comme ça.
Pas grave. C'est mieux, là?
Ça ne va pas.
Là, alors, attendez, je bouge. Là. Voilà, ici. C'est mieux?
Oui.
Allô?
Oui, oui, oui.
Oui.
C'est mieux, mais c'est pas immédiat. C'est-à-dire qu'il faut commencer à parler, on va voir si ça se maintient.
Voilà, alors je parle. Est-ce que je parle assez?
Très
Pour
bien.
que ça se maintienne. Comment? Et là, c'est
Ça
mieux?
paraît bien. Oui,
C'est mieux, là?
Ça a l'air.
oui, je crois.
Ah, voilà. Alors, I was saying that to find
Non, ça va pas.
Oui.
Ça va pas.
c'est bien?
Non.
I think it's a microphone problem.
Non, attendez. Je vais sortir dans la rue, alors. Attendez. Et là, c'est mieux? Non? Apparemment, non. Et là,
Alors,
ici?
alors à ce moment-là, c'est peut-être le micro, je ne sais pas.
Non, le micro est au maximum. Voilà, bon, voilà, écoutez, je vais crier. Vous m'entendez maintenant? Allô?
Oui, oui, oui.
Vous m'entendez?
Oui.
Pas très bien.
Bon, mais attendez, je vais parler très fort. Là, maintenant,
Oui.
vous m'entendez? Là, ici.
Oui, très bien. Allez-y.
Ah, je suis près du routeur. Je ne bouge pas. Je ne bouge pas. Je suis debout, mais je ne bouge pas. C'est bon?
Très bien. C'est bon.
Bien.
Bon. I said, find the orifice.
Ça ne se maintient pas, the sound is not maintaining. The sound, we can't hear you.
Okay. You cannot hear me.
Now we can, and then when you continue talking, it doesn't maintain.
Okay.
And sometimes you are frozen.
It vanishes.
Okay.
I'm sure it's an internet connection problem.
Yes.
No, I think it is internet. But it's too late to put the fiber now. It's too late. Okay, anyway. What I said, I repeat. To have 7 bites at the orifice found is due to the dissection of the second surgeon, not to the truth. Do you agree for that?
Yeah.
Yeah.
Yes.
I think, for example, also in the description of the right hepatectomy, he's left with 4 bile ducts.
It's
That's not
impossible.
usual after a right. So
That means that the second surgeon did a huge dissection so that to find all the bile ducts. And he went very high in the highest, opened all the second duct. In addition, he did that he did, but not to do. Now we found 3 errors. One, the dearterization considers that the dearterization was an indication of right hepatectomy. 2, he did a huge resection of the ileus in order to find the orifice. And 3, he did that for what they call a very early report. Do you agree for that? The 3 mistakes?
yes.
Yeah.
Okay. And what the follow what happened after is a consequence. Can you imagine to do immediately after the operation to do a Roux-en-Y on the 3 ducts on the left immediately? That means they were very, very small, not dilated. And to have a stricture, to have by leak, and the operation, the consequence. Do you agree? Hello?
Yes.
Yes.
Okay, now, so we found 3 errors. Did you find more?
May I say something?
Yes, Eduardo.
What was the time for the laparotomy? How many
I don't
times
know.
after?
No, I don't know.
immediately?
This is a case published.
Yes, but is that the laparotomy was made how many times after the first surgery?
But you know,
Because after laparotomy,
Eduardo, I am not the surgeon who did that. This is a publication.
because the principal error must be to do the laparotomy very soon, as Hugo said.
Of course, I agree, of course. That means, let me go later. I think what after the consequence, I think, as you know, that when there is a leak, let it finish. Not what happened after the operation. Relative episode of cholangitis, Hépato-Biliares. And here we enter is a terrible period of a lot of error and bad percutaneous drainage procedure. Consequence of this infection, the patient, as a young patient, severe endocarditis with mitral aortic valve insufficiency, mechanical replacement of them, At the end, secondary biliary cirrhosis. Only one remark. 19 months after the biliary trauma, you have secondary biliary cirrhosis. In the report I did, it was between 2 years and 5 years, usually more than 3 years. Here it was 19 months. It was a very evolution toward the biliary cirrhosis due to cholangitis. And at the end, I think he did the surgery on a patient with infection, and the patient died of cardiac 7 days after. So, Laurence,
Yes.
you publish a review on liver transplantation in bile duct injury, no?
Yes, I did. It was the French experience of 30 cases of liver transplantation for bile duct injury post-cholecystectomies. And you summarize all the problems of these type of liver transplantation that is really extremely mortal and morbid, because we had 25% of death and 80% of very severe morbidity. And you show that the problem is not only the severity of the bile duct, but the management after the bile duct. And here, obviously, the decision of liver transplantation was taken too late, very too late, with a patient with sepsis, with cirrhosis, portal hypertension. It was doomed to fail.
Yes.
I think Professor Matur wants to speak.
I want to make a very philosophical comment, is that after 30 years, almost more than 30 years of introduction of laparoscopic cholecystectomy, why we are seeing such horrible injuries, we still continue to see, number one. Number two, all of you are so senior, Professor Bismuth. During the open era, before 1990, were you seeing this type of injuries, and what were the incidents requiring liver transplant at that time? Because it's a matter to be looked into very seriously.
I don't keep your question. Okay. What you said.
So during open era, before 1990, before a laparoscopic cholecystectomy came into picture, were you seeing this type of bad bile duct injuries?
Look, I never observed a case of bile duct injury going on the left. Usually it is the right. When we did some trauma during cholecystectomy, it is on the right. How to go to the left? The stricture, the evolution of the stricture. After repeat reoperation, may go to the left, which is the type of left. So, but it is usually due to repeat operation. It is evolution of the stricture. It is not the trauma. Usually the trauma, the maximum is to put the confluence to the maximum. This is the maximum. But not to go so far, to go to the secondary confluence of the left. I never observed that. Never. Stricture, yes. Trauma, no.
Can I?
Yes, Laurence, yes.
Can I speak? Because in the French experience, to answer the question of surrender, we had 66% of bile duct injury after laparoscopic surgery, but we have also 33% of a patient who underwent a laparotomy. And it is true that we know that the severity of the bile duct injury increased with the laparoscopic area for different reasons. and the major one is that the bile duct injury is associated with vascular injuries, but not only with thermal injuries. So it is more extensive, is higher in the hilum, and so the damages are a lot are more severe than in laparotomy. And the last point is that sometimes they do bile duct injury in laparoscopy, and then the conversion worsen the bile duct injury because the dissection is extensive to try to understand or repair the bile duct injury. So I think that you're right. The severity of bile duct injury increased with the laparoscopic area.
So my supplementary thing is that comment is, should we not revisit the laparoscopic cholecystectomy as per the technology? The critical view of safety and all that is fine, but is it that in the open era, the diathermy used for dividing the cystic artery or dissection was much less? It was basically a dissection with the right angle ligation and then dissection. So is it the excessive use of the energy in that area, which is one reason which should be looked into and should be perhaps thought that one should not use it? Okay, which is that's one. Second, this misidentification of the artery, right hepatic artery and ligation. Again, one has to revisit the technique of laparoscopic cholecystectomy in that case. Why there are so many? Because this is 32 years. It's a good learning curve. I don't think there can be better learning curve than 32 years for any surgery.
Okay. May I ask you a question? I would like to come back to the conference. I am blocked on my slide. How to do? To go out?
Escape.
My
Escape.
Slide. Escape. I escape several times. I cannot succeed.
Or quit.
Quit. Well, not to quit.
Professor, I think where you see present now, you can to stop presenting.
Oh, I think you should minimize the PowerPoint first and then reopen Zoom, and then you can quit. Yeah. And then reopen the Zoom.
Yes.
Reopen the Zoom.
The Zoom,
Where is the Zoom?
I think on the right, or more on the right, I think.
On the right.
Or on the other side of the screen.
You see me?
No, the other side, I think, yeah.
Okay. I think I am.
Yeah.
I come back.
Are we?
Oh, good.
Fantastic. Oh, I think you left.
Yes, he left.
So
We
I
will
would say in the order, I think the next case is Tom Cato.
Okay, all right. Jonathan Mirola.
We should perhaps wait a little bit for Professor
Yes,
Bismuth to
Professor.
come in.
Yes. Thank you. It was really interesting case, but I want to share something very interesting case. I did a Whipple for somebody who already had a right trisegmentectomy at a tumor on the hilum, the pancreatic head, and it was a GDA branch was really feeding the liver, and a common hepatic artery has a stenosis. I didn't realize that because once he clamped the GDA, there was still flow, but there's a lot of flow from the tumor was feeding the liver. So then after Whipple is done, the liver lost the artery, but there was a stenosis of a common hepatic in this bifurcation of the splenic. So I asked the IL to do a balloon, but instead of IL fixing the balloon, they completely dissected the celiac. There was no flow in left gastric, splenic, common hepatic, zero flow. I thought the liver is gonna die. I just talked to the family, it's gonna need a transplant, but you know the liver survived. Liver survived.
No
do you know
more
what the artery is feeding the liver?
It's probably a phrenic artery.
No, it wasn't phrenic. It was not phrenic. It was adrenal artery.
Oh, nice.
Yeah, so I don't know how the left adrenal artery take over the common hepatic artery, but it was amazing. But it did happen. So,
You know, I have
Luck.
the Professor Bismuth is here.
This is what I said. If the liver is in altitude,
Yeah.
if the liver is in altitude, not dissected,
Yeah.
there is always arterial lymph.
some artery, right? But do you know what happened to the patient? Patient got a terrible gastrojejunectomy leak because of that and suffered a consequence of Whipple. But at least the liver survived, you know.
But I should say, for example, on this situation, we have a patient where we performed for a Klatskin tumor, a right extended hepatectomy with portal vein and artery resection. And we had an artery thrombosis that was not possible to reconstruct. And the patient, I presented that once here. We presented here a long time ago. And the patient is still alive. And there's a phrenic artery feeding the liver.
Yeah, yeah. Phrenic artery, adrenal artery. There's a lot of, like you said, 21 artery that feeds the liver? Is that what you said, Dr. Bismuth?
I will send you the reference. It's Michel. Okay, now I have to do the last comment. The only liver transplantation I performed for bidectomy was an emergency. The surgeon doing the cholecystectomy as a unibody, he tried to put clip, it was before laparoscopy. He tried to put clip, to put clamp. At the end, he ligate the portal pedicle. And then the patient arrived in a picture of pulmonary, a total ligation of the portal pedicle. So, you know, this is what we said. It is not the deprivation of the arterial. It is both portal and arterial.
No. Daniel,
I think that liver transplantation must be very rare in bidectomy, and is a consequence of a lot of mistakes. And the main mistake, not the first surgeon, is the second surgeon. You know, I was sometimes expert in this kind of case of complaint, the family and so on. And it's terrible. For the first surgeon who did the cholecystectomy was charged. Indeed, it was the second one. All the mistake was performed by the second one. And the second one has nothing. All the fault was on the head of the first surgeon. Of course, he did a mistake. But the second one said what as it okay, finish. Thank you. But only one. This is a new type of presentation. If you agree, if you find some case with error, it is very instructive to discuss about the error. Okay, thank you. May I sit now?
Yes, you can.
Yeah. I think Danielle wanted to say something.
No, I just wanted to come back to Tom's case. Hi, Tom. It's the liver can survive on the portal vein. It's the bile ducts which are at risk here.
Yeah.
In the Whipple is like transplants. You transect the bile duct, and if you don't have an artery, you have ischemic cholangitis.
Yeah, most likely she's going to develop it.
You know what happened to your patient,
Yeah.
and you said the liver survived, but did the patient survive?
Yeah, so the liver on a patient so far is surviving.
And what about the bile ducts?
But most likely she's going to have a multiple bile duct injury. The GGT is high, but she didn't have any issue right now, and she had a PTC across the liver. And then that seems to be very healthy, the peripheral duct, except for the anastomotic stricture. So far is okay, but I think you are right. There's probably not going to be a long-term survival. But at least, the fear of doing acute liver transplant wasn't necessary, which was good for the tumor case like this.
Okay, so Tom, you have
Yes.
another presentation?
Yes, please, Jonathan.
Loras, you were saying
Yeah,
something.
Jonathan Rolla.
Yes, just to finish the discussion about the bile duct, I agree with Danielle. Usually there is bile duct problem. It's not exactly the same than transplantation. In transplantation, you can have biliary problem very late after the thrombosis, but in Whipple procedure, it's often very early. So you have the abscess, and it's in the postoperative earth. So, Tom, I hope it will be okay for your patient after. For this, I think so.
Yeah, it's most likely
it's a little
not
difference
okay.
between transplantation and a Whipple.
Yeah. Okay, Jonathan, you have to minimize the Zoom, the Safari, and then maximize
Okay, let me do that.
Daniel,
presentation.
Daniel,
Oui, yes.
I cannot. Now I am forbidden to speak, and you take chairman.
Me?
You, yes.
Okay, good. It's an honor. So please proceed, Dr. Merola.
Okay, great. Is everyone able to hear me okay and see the screen?
Not
Yes.
not seeing the screen for me.
I see that I can see the screen.
Yeah, we can see it.
Yes, I can see the screen.
Presentation? Okay,
No,
then
but you-
maybe, yeah, I know the presentation, so you can go ahead. I just can't see it.
Okay.
We can see very well. We can see very
Why
well.
is that? Why I can't see it? Did you minimize the Zoom?
I did, yeah.
Okay, go ahead.
So our patient's a 55-year-old lady with a history of primary sclerosing cholangitis and ulcerative colitis that was first diagnosed in her 20s. She had a stable disease for many years, but developed progressive portal hypertension with varices noted on endoscopy that was managed with beta blockade. She had never had any decompensation events from her cirrhosis. And she presented for hepatology evaluation where an MRI was obtained and noted a 1.5 centimeter polyp in the gallbladder fundus. Her labs were fairly unremarkable with a platelet count of 199,000, normal transaminases, a normal bilirubin of 1.4, and a normal INR. Her tumor markers were within normal ranges. And on exam, she was anecteric and had no lymphadenopathy. Here is her MRI. And as we scroll down, you can view a 1.5 centimeter enhancing mass in the gallbladder fundus, which is coming into view here. And there's some sequelae of portal hypertension as evidenced by splenomegaly and gastric varices. She had a CT chest done that revealed no evidence of pulmonary metastases. So the patient underwent a robotic cholecystectomy for diagnostic purposes. The gallbladder was dissected and removed without spillage through a bag, and the specimen was opened, and a photograph is shown here, where you can see an irregular mucosal lesion located on the peritoneal side of the gallbladder. The pathology confirmed adenocarcinoma of the gallbladder, moderately differentiated, measuring 2.5 centimeters with invasion into the muscularis propria. One node was included within the specimen, which was negative. So to summarize, this was a child's acirrhotic with portal hypertension and an early stage gallbladder cancer. Question to the group is, what would you recommend as the next steps in management?
So in a usual recommendation would be a lymphadenectomy and extended cholecystectomy. I'm not too sure really the extended cholecystectomy is necessary in this case, but lymphadenectomy is debatable. She developed some ascites now, mild ascites now after just the cholecystectomy. So really the benefit of lymphadenectomy versus the risk of decompensation or losing quality of life for this patient, because this is a gallbladder cancer. She's not going to be transplant candidate for a long time. So what you guys would do in this type of circumstances is the question to the group.
John Isaac?
So maybe just consider the fact that this is on the peritoneal side, which is probably a better prognosis than if it is on the liver bed side. And you know, I'm not sure what her liver functions, but I think your concern is the decompensation if you do a bed resection. So I would have a more minimalist approach and just do the lymphadenectomy for this patient.
But is a really lymphadenectomy prophylactic? Is a lymphadenectomy prophylactic for recurrence? Is this really a diagnosis purpose?
Yeah,
because if she's not going to get a chemo, unlikely that she would tolerate the chemo, then would you really do it? Is that necessarily? And also the evidence of this is a T1B gallbladder. Is the evidence of T1B, the benefit of lymphadenectomy, is that evidence strong enough? Because it's been written, it's been really in everybody's mind that is the right thing to do. But if you look at the evidence, there's no randomized trial done. It was all retrospective data analysis. And also there was no strong, there was always a confusion between lymphadenectomy itself had the preventative effect on the recurrence versus just the diagnostic purpose. If you do lymphadenectomy, lymph node is positive, you give chemo, that's why the patient live longer. And it was never really clear in any literature. So is this really truly necessary to do it? Number one. And secondly,
wanted to speak. Hugo?
Yeah, go ahead.
Hugo?
Yes, I was just going to say that I agree with John. Probably a T1B would be an indication for a resection, a liver resection, but if it's on the peritoneal side and considering that the patient has a marginal liver function, in this particular patient, I would consider lymph node clearance of stations 12 only. I think for the benefit of lymph node clearance, I think the only tumor where this is shown to have an impact in prognosis is in gastric cancer. So all the others, I think, we are not sure. I would tend to believe that lymph node clearance also has an influence, an impact on prognosis on gallbladder cancer or in cholangiocarcinoma, but until now we have no reason to say that. In this case, I would do a lymph node clearance for station 12 for the hepatic pedicle.
Laurence? Laurence?
I'm not sure I agree with that because it is in lymphadenectomy in this patient will be extremely morbid. She has ascites only with a cholecystectomy. And we have to be aware that in T1B gallbladder cancer, the rate of positive lymph nodes is less than 5%. So you would do this lymphadenectomy for nothing, only for complication in 95% of the cases.
May I say something?
Good point.
Okay.
May I try to say something?
Sure.
Child play is not an indication to do a liver resection. And in this case, it is first, I think, to do a B-segmentectomy for him. No? What do you think? Laurence, you say no. And
No, for a T1B, it's not necessary to do a bisegmentectomy. It would be necessary to do if the cancer is on the liver side to do a typical
Gallbladder bed resection.
yes, a bed, liver yes. Gallbladder bed resection, but not a bisegmentectomy. But in that patient, all that is extremely dangerous, I think. So, well, in my opinion is that I wouldn't do anything more.
the recommendation is to do a lymphadenectomy, and in the papers, there's no real differentiation between peritoneal side and liver side in terms of gallbladder bed resection. And there's no evidence that it improves prognosis. It's mainly a staging procedure for chemotherapy. I don't know what's your experience with that, but most of the time we don't find anything on the specimen or on the lymph nodes.
Yes.
When you find something, survival is very poor.
Right.
So that's my point.
You're right.
I have a question to Tom. Why did you do this robotic to do a cholecystectomy? And I guess if you used a robot, you should have removed the lymph nodes at the same time. Would have saved this discussion.
Yeah. So, yes. So the reason I just don't want to spill it, just make no mistake in spilling the bile. I thought the robotic was better because I'm not a laparoscopic technician like you. So my, technique level for doing the cholecystectomy and robotic versus non-robotic is very different. So probably like Danielle would just do a laparoscopy, and then probably wasn't any.
Not me, everybody would do for a cholecystectomy. But for one thing that has been said with the robotics is that it helps the lymphadenectomy.
Yes.
Rather than, and I have another question to the group. Gallbladder, this patient has PSC, right? Primary sclerosing cholangitis.
Yes.
This is a risk factor for gallbladder cancer.
Yeah. Yeah.
So maybe one thing we could comment on what you've done, which is excellent. What you've done is good. Is maybe you could have taken station 12 lymph node at the same time.
Yeah. The reason I kind of hesitated was there was a good enough, dilated vessels around the field.
Understand.
And then it was a little scary because one shot of mistake is going to be an open, case. And if you do the open case, then risk of decompensation even higher.
You're right.
And at that time, we didn't even know that was cancer or not. Well, I could have waited, but I didn't really too much. We sent it to Frozen, at least to look, but it was not. So, what do you guys more collectively think? Should we do nothing for this, or?
So who would operate? Who would do the lymphadenectomy?
Is that also another question? Is lymphadenectomy be open or laparoscopy?
You could do it robotically, but if you found large vessels like signs of portal hypertension in the hilum, I wouldn't do nothing.
Before I would go ahead, I would do a good angio-CT, and I would check for collateral circulation and see how it looks. And personally, I would not reoperate on this patient.
I agree. Do nothing.
Okay, sounds like that's the majority, and I agree with that because I was really hoping that you guys would say that because I didn't really want to operate on her because she had excellent quality of life. She may need a little diuretics now, but it's not affecting her life. But if you do something and bad mistake and she's not getting liver transplant, we're gonna set ourselves into a terrible patient with a bad complication after the other. So that's sort of my take, and I'm glad that the majority agreed.
I think the next case is Fernando Alvarez. I don't know if I don't see him here.
Yes, I'm here, Professor Marquez.
Okay, Fernando.
Hi, everyone. Do you hear me well? I will present. Well, thank you very much for this opportunity to have your advice. Let me see if I can share. Do you see my screen?
Yes.
Okay. So your advice will be of great importance to me in this case because it is a complex case, but I thought it was pretty much straightforward in terms of decision making until a pathologist, as usual, came across and really changed everything, and I'm a little bit lost now. So this was a 70-year-old woman. Her past medical history was remarkable only for a cholecystectomy more than 15 years before. She presented with weight loss and jaundice in April. She was managed first in another hospital. Her ultrasound showed an intrahepatic bile duct dilatation with a 23 millimeter nodal lesion at the biliary bifurcation. This was her laboratory test. You can see a very altered liver function test with a cholestatic pattern, almost 16 bilirubin and ALP of 800. They perform an MRCP, and as you can see, there is a mass here probably which compromises the biliary bifurcation. And this is her complete scan where you can see the lesion here and the dilated bile duct. So this was decided elsewhere. She received the percutaneous biliary drainage, the left one, internal, external, and she developed the severe acute pancreatitis as a complication. This was a 10 French catheter, probably too thick, and it took a while for her to recover. She had a severe renal insufficiency and some fluid collections around the pancreas, but no more than that. She comes to me more than 1.5 months after that with almost normal laboratory test and no cholestatic pattern, and the CA99 was over 1,000. So to me, it was pretty clear that this was a periilar cholangiocarcinoma going to the right side. She had an occluded right anterior portal vein, a patent left portal vein, a patent left hepatic artery. She was staged with a CT scan, and no disease was in the thorax. So everything seems to show that this patient could be a candidate for resection. I did the volumetry that was fair, so I didn't embolize the right posterior portal vein. And when she was admitted to the hospital the night before surgery, I said, okay, it's almost a month after the last CT scan, we will repeat it. And here is the CT scan. You can see this mass-forming lesion, periilar mass-forming lesion has grown, progressed, and she developed this tissue in the portal pedicle, probably lymphadenopathies.
Sorry, Fernando, that's what I was asking you, because when you showed the artery for the first time, it looked like you had also some tissue around.
Some tissue around. Yeah, it seemed, but it wasn't pretty much clear in the first. But now it was not like a lymphadenopathy, but this tissue that was around the portal vein, she had a severe stenosis of the portal vein, and you will see here, this tissue was also in the portal pedicle up to the celiac axis. And I recall she had a previous pancreatitis, but most of the fluid collection had resolved. So this to me was a progression. So
what happened to the CI 19.9 after the drainage?
It was over 1,000 after the drainage.
Still.
So to me, it was pretty clear that it was not a false positive elevation of that. It was normal. So I did a staging laparoscopy the day after that. I say, okay, she needs a palliation for the portal vein and for the biliary axis. So she had carcinomatosis, and the frozen section was positive for malignancy. There you can see the nodes in the peritoneum. So by laparoscopy, we cannulated the inferior mesenteric vein. This is the portogram. You can see almost a complete stenosis of the portal vein. So we placed a portal stent in the portal vein and a biliary stent in the biliary tract. So she was palliated, and this is the control postoperative CT scan. You can see the upper edge of the stent is below the bifurcation, and the lower edge is above the mesenteric, superior mesenteric vein, splenic vein axis. So, and she had a good flow in the left. So up to me, everything was okay. Her laboratory was almost normal, as you can see, and she was about to start chemo, and this is the final pathology. So the pathology says, I made a mistake. There are no malignant lesions in the peritoneum. These are tuberculoid granulomas. Pus and Ciel-Nielsen stains were negative for acid, fat, bacilli, and fungal structure, but this may be a false negative. In summary, This is a 70-year-old woman with imaging suggesting a locally advanced mass-forming ileal cholangiocarcinoma, Bismuth type 3A. She has over 1,000 of CA19-9, a FALF-positive frozen section for carcinomatosis. She has palliation with stents. And this is the other side of the story. Definitely pathology, negative, good performance status, no lung disease, no fever or other TB-related signs or symptoms, and she has normal liver function tests. So this is my questions to you. How would you manage this patient? Would you consider chemo if this is a tumor, upfront resection, empiric 4-drug TV therapy, or would you further study these patients? And these are my proposals, options.
Let me just make a comment. I think we have seen several cases of peritoneal tuberculosis mimicking carcinomatosis, but I don't know if Eduardo recalls any case of intrahepatic tuberculosis. I don't.
No. I believe you need
that is strange.
You need a biopsy of the main mass.
Yes.
Yes, I have reviewed the literature, and there is some evidence, some published case reports, mainly from India and Asia, where tuberculosis is endemic, and there are many reports of hepatobiliary tuberculosis mimicking exactly an ileal cholangiocarcinoma. So PET-CT, I would like to review these options. PET-CT has been studied and didn't make really a difference in terms of decision making because the TV can be positive. Percutaneous transhepatic, I thought about it, but probably has more complications. That spyglass, I think with a stent won't be possible. Re-laparoscopy, maybe, but more morbid. And I thought, why not intraocular ultrasound, endoscopic ultrasound, and biopsy, or bile sampling and PCR for tuberculosis that has been described, and usually it has a good sensitivity. So those are my proposals. Do you agree with that?
Professor Matur has raised a hand.
Yeah. So basically, we have to establish that this is not the coexistence of hilar cholangio and the tuberculosis.
Yes.
Sometimes, rarely, you can see the two. And that's why what Daniel said is right, that you have to have biopsy from the main mass. Okay. How you obtain? You can do it percutaneous, transhepatic biopsy. You can use the spyglass, and whichever, either it confirms tuberculosis, rules out malignancy, then treatment is antitubercular drugs. They all resolve. But if it is a coexistence of tuberculosis with malignancy, you treat the tuberculosis, and I don't know what we'll do with the malignancy.
I would say also that perhaps spyglass or PET-CT or re-laparoscopy for me makes little sense. I totally agree with Professor Matur. I would do a biopsy of the main mass to be sure that you haven't got cholangio and this disease, because it's not customary to have two diseases at the same time, but you have a CI 19.9 of 1,000.
Yes, that struck me also. Thank you for all the comments. And
yeah, may I say something?
Yes.
You don't need any biopsy. You don't need any biopsy. You have already all the information that you need to treat that patient. You only need biopsy if you need to do chemotherapy. Please treat that patient as they have the cholangiocarcinoma and forget the other things. Treat the patient immediately with resections, if this is possible, because you have this result at the end, and you are going to see that you have done well. You don't need biopsy now. You don't need the biopsy. Go ahead and treat the patient, please.
It is true that most of these patients or reports have been diagnosed with the final pathology, TV. So it seemed like it would be okay resection, but when I still read the literature, there are many cases that with TV treatment, they have a complete response and do not need surgery. She has stents in place, so that would be probably an argument for resection after TV treatment, but I made this like probable algorithm. So I say if she has cancer, chemo, no doubt. If this is hepatobiliary tuberculosis, do we do TV treatment and wait? And if it responds, do control or resection? If it does not respond, or we want to remove the stents, or do we go on as you have proposed with resection and then TV treatment if it is confirmed? But probably she has both diseases, as you have also mentioned. So, what to treat first? So it's a very tricky scenario to me. So I think it's best to biopsy both, biopsy the lesion and probably take a bile sample. And if that's positive, I think she has TB. It's obvious if the PCR is positive, and then see with the percutaneous biopsy of the lesion if she has both or not. If she doesn't have both, probably it's appealing to just treat the TB, wait until, I don't know, 4 or 6 months to see response, or every 2 months do a CT scan and see what happens. What do you think?
Daniel?
She's going to die.
No, Prashant has raised his hand.
Prashant, sorry.
Yeah, thanks. So I just wanted to say that the appearance on the CT scan is not at all tuberculosis. The appearance is not like this when you have tuberculosis of the thing. It's more of lymph nodal disease, more of extrinsic compression. If at all, it will be around the duct. This is a hilar cholangiocarcinoma. Look at.
Okay.
And I think that you have to go ahead and treat it. There are two other things. One is, yes, that even if you're doing a resection, it wouldn't harm to clear your mind as well as probably clear the patient's mind by doing a biopsy. It can be a spyglass. I think it should be possible, just to make sure that you have a clear-cut thing about going ahead, but you will have to go ahead. And the second thing is that I think the only area here where the resection may be a little difficult is the portal vein, because you've got the left side, so you probably will have to resect the portal vein and do maybe a type of a Rex procedure where you have to anastomose it to the left portal vein with a jump graft. So that would be the only thing. But other than that, I think this patient needs a resection.
You would at least...
Thank you very much, Prashant. Thank you very much. The old man is very happy.
Daniel?
Yes. No, I just want to say, if we go back to the last CT, I agree with what Prashant has said. I believe she has cancer. Yeah. And if we go to the last CT, it's a perihilar, but it's so intrahepatic. It's a very big mass, actually. And I'm not sure that it's going to be so easy to get it to get a biopsy out otherwise than by a percutaneous, and it's very and I wouldn't go into a resection. This will be a very difficult resection, potentially with a high risk. And I agree with Prashant, and that's what I said first. You need a firm diagnosis before you go in an operation like that. I agree with Eduardo that most of the cases you don't need a biopsy. And occasionally we operate on patients with benign disease, by the way. But in this case, no, the last, we didn't have time to see it well, but what is the last CT? This is the last CT?
This is the one before the placement of the stents.
The one before surgery, the one you showed before surgery.
This one. As you can see, this, I'm not sure I will be able to resect all this. Because this is, I think it's tumor around, you have the celiac axis there. So I think she has a locally advanced, if this is an hilar cholangiocarcinoma, I think she has a locally advanced disease that it may be operable and even resected, but I don't think it makes sense from a biological point of view. I'm not sure.
I think even the celiac trunk looks involved. And I agree with...
biopsy, my friend.
Yeah, and I agree with Danielle. I think this is a perihilar, but what this is an intrahepatic cholangio with secondary invasion, because true clad skin tumors don't reach this size usually.
Okay.
But if you show the last CT on the one you put on your slide.
Let me see.
This one, the day before surgery.
The day before surgery is this one. Is the one I was showing. Yeah. This one.
You can get a percutaneous biopsy here. No, not this one.
Yeah.
No, one between.
The other one.
Between.
Yes.
This is a tripod extended to the bottom.
Yeah, I thought so. So like mass forming or periilear intrahepatic.
With possible with extension to the island.
Yeah, the thing is that the pathologist is pretty much confident. She told me this is TB, or I don't have the
peritoneum is TB. This is, you need to know what this is in the liver.
So I know you want to rule out that she doesn't have both diseases at the same time.
I think she has. I think she has.
Yes, of course she has both diseases. Of course she has those, and that's for that you don't trust the image. The image is tuberculosis and cancer. Please treat the cancer and treat the tuberculosis.
Okay.
But she's inoperable.
Yeah, at least right now. We agree.
Yeah.
So we should see response, and if she responds, whatever she has, would you go and resect the portal vein stent? Do you have any experience in portal vein stents for a long time? Thrombosis in the long term, or any experience? Does anyone have any experience on that?
I think only in transplantation.
Yeah.
People.
And as Prashant said, this would be a case for erection. You probably would have to resect. You probably would need to resect the stent.
Yeah.
Go down to behind the pancreas, like you do in transplant. You put a graft and the SMV, and then you put it to the rex.
Yeah.
This is very theoretical because I think she has neuroplastic pediculitis. In French, we say pediculite neoplasique. I don't know if you say that in term like that.
Yes.
Okay, so
just a question: how do you what do you think of this portal stenosis? This portal stenosis is because of cancer. It can't be otherwise. So for me, it's completely palliative. I don't understand. You can imagine that chemotherapy will treat all this infiltration in the celiac axis, and the resection will be so palliative, even with therapy.
Yes, Professor Chichi, I agree. I was only asking if this was, because I want to think in positive. If this was a TB, that would be very, 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 I agree with all of you, would be very rare. But if this was, and she has a response, let's say she has a response, because I have read some case reports of hepatobiliary tuberculosis with stenosis of the portal vein, just as this patient. So that's why I have this window open. If this was to be a response, would you take that portal stent?
Just another question, please. Do you have PCR for tuberculosis positive?
No. I will take the sample on next Monday. I will take the sample because I just figured out about this. This is
because just a question, because your pathologist said it was tuberculoid nodule, and you can have that when you have pancreatitis or inflammatory, and it's not always tuberculosis. I wonder if she has really a tuberculosis, in fact. I think she has a cholangiocarcinoma only.
Yeah.
That would be a good point. If you have seen, I don't have any experience, but if you have seen like tuberculoid nodules in pancreatitis, she had a pancreatitis. I didn't consider that as an option. She had a severe pancreatitis with local changes, complications. So that may also be an option, a false positive for pancreatitis. So, okay. Thank you, everyone, for the comments and advice, and I will do the biopsies and keep you informed.
Professor Surendra.
Yeah, just send the slides to India for review of the pathology. Okay. Indian pathologists are quite used to diagnose or not diagnose tuberculosis.
So I think our next, John.
Okay, thanks, Hugo. Like to present.
I will.
I'm hearing echo. I don't know if you.
Yeah, turn off your microphones, please.
Okay, thanks, Hugo. We'd like to present a case from Birmingham where we like the advice of the companions for how we're going to manage it. I'd like to introduce Bobby Dasari. He's a colleague of mine. He's a consultant surgeon at Birmingham, is a transplant and hep bill surgeon. and Bobby is going to present this case. Why don't you minimize the Zoom panel, Bobby, and just go to PowerPoint and present it. Yeah, we can see the PowerPoint. You can maximize it and go to the front slide, yeah. Can't hear you, Bobby. Are you mute? Bobby, are you trying to share the screen? And we can't hear you.
Can you give a phone call to Bobby?
Yeah, I'll give him a call and see what's going on. Okay. I think he's having trouble. We cannot hear him. I don't think there's anything that we need to do. We need to just click the microphone and start talking. Can you test the mic? Okay, I wonder if they can hear you if you speak on my phone or not, if that's possible. Can you start talking and present it? No, I don't think you're getting a mic.
Maybe he's using AirPods or he's using some this thing which he should just disconnect and use probably the speaker of the
You use the
system
computer.
itself.
Yeah, that's a good
Yeah.
point. Are you on AirPods or anything like that? Use the speaker. On the settings, just go to the settings on Zoom and yeah, MacBook microphone. Yeah, it should work. Okay. You say you're trying to talk.
Can you use your phone as a speaker?
I'll try that. Yeah. You want to talk into my phone, Bobby? Talk into the phone and see if you can use it as a speaker. All right. Yeah, we can.
Yeah, but we can barely hear him.
I think we're gonna get. No, it won't work.
No, it won't work.
It won't work. No, it won't work. So much echo.
No, his mic is off here.
Yeah, I think you're muted. Can you make sure you're not muted?
No, he's not muted anymore. Well,
Maybe let Bobby drive the PowerPoint and somebody else present.
Yeah, I think that's what we'll do. Okay. Okay. Right. So Bobby, you'll have to. Can you hear me? Yeah, I'll tell you when to move the slides. Okay. So sorry about that. So we're going to present this case. It's a complex cystic lesion of the liver, and the patient has developed a nitrogenic portal vein thrombosis as well. Okay, Bobby, could you maximize the presentation? Yeah.
Click on slideshow.
Click on slideshow and then maximize it. Yeah.
No, the slideshow on PowerPoint.
Yeah.
And then here.
Open it up. Yeah.
That's
Okay.
right.
Okay. Good. So this patient presented to a center, not our center, but close to us. Patient was diagnosed with a cystic lesion in the liver, had 2 or 3 attempts at surgery, and was finally referred to us. And what we'd like to do is really discuss the surgical options of this case, who is now, experiencing some difficulty. So going back to the story, she's a 32-year-old female, fit and well. The only medical issue, she's on thyroid supplements, and presented originally with upper abdominal discomfort. So next slide, Bobby. You move the slide. Right, so we're just going to run down the original MRI, which was a presentation in June 2020. So could you run that, Bobby, please? Yeah. So you can see she's got a cystic lesion, sizable cystic lesion. Could you run the video, Bobby? Yeah, I'm seeing it. Yeah, it's not running. The video is not running. You can see it moving. Maybe if you go to the, are you on the slideshow? Yeah. Okay, try it again.
Click on the arrow.
Yeah, click on the arrow. Yeah, I think he can see it moving, but we're not able to see it moving. Try that.
Oh, it's all the way. Let's
No,
do
it's
it
all
back.
the way. We cannot see it moving.
There we can see something.
It's not. We're not seeing it. No. We're not seeing it. Okay. Well, why don't you try to move to the next slide? No, we can't see the next slide. Okay. I'm not sure, Danielle, if we cannot show the videos. I'm not certain whether we'll be able to discuss the case. Anyway, we'll just try to push on. So actually this patient, there you go, yeah. Yeah. Okay, Bobby, I'm not sure. It's sort of moving and jumping around a little bit. Yeah. I think probably we should abandon this. Let's see if we can fix it. I don't know, Hugo, is there anything else to present?
Maybe
Yeah, I'll try to sort it out in the background.
Maybe he can send it. He can send you the presentation, and you do it from your end. Maybe you can send it to you using WeTransfer or something like that.
Okay, we'll try that.
Sending you slides. The slides. Do we have another case? Hugo? Hugo? Hugo, we have another case?
Yes, we do. We have a, I think it's not a long case, it's a short case. And I ask João to present. João, our resident. So João, go ahead, yes.
Good afternoon, can you see my screen?
Yes.
Okay.
No, not yet, João.
No, we are on the other, yeah, curious.
Yes, yes.
Curious case, okay, I will present in full screen.
Okay.
Okay. Thank you. It's my great pleasure to be here and to present to you one of the most intriguing cases from our center. This is the case of a 68-year-old male with alcoholic cirrhosis and no evidence of B or C virus infection. He has a MELD of 11 and he has no remarkable past medical history besides this diagnosis of diabetes, hypertension, and dyslipidemia. He presents with complaints of asthenia and mild pain in right hypochondrium, and his blood workup show only slight changes in liver function tests with elevated alpha-fetoprotein of above 4,000 nanograms per milliliter and an elevated CA 19.9. Unfortunately, these images are not the best. The exam was done outside our hospital, but we can guess here a large diffuse lesion in the right lobe starting here. Here is the right suprahepatic vein. Here we can find a bulging of this lesion over the right portal vein that continues inferiorly with this heterogeneity, perhaps more evident here, here, down. Let's take a look at the chest CT scan. We find multiple bilateral lung lesions. We have also these large, the largest lesion has 2.5 centimeters here in the right upper lobe. And we also have these 3 centimeter large lesion in the mediastinum. At this point,
At this point, we would ask, what would you do? For the time when it was referred to us. Any thoughts?
The scan again.
Starting from here.
So my recommendation is get a new imaging.
Yes, obviously.
Can I proceed?
So in fact,
I would actually, if I can say, maybe the new imaging should be a whole body FDG18 PET scan along with a triphasic CT scan of the abdomen, because I think that this patient has got significant large amount of disease outside the abdomen and outside the liver as well. So if you have a concurrence of the tumor and that extrahepatic disease, it will save you a lot, because I think it's going to give you, probably directly give you the diagnosis. So I would do a whole body PET scan with triphasic CT of the abdomen, CT angio of the abdomen.
What we did, and sorry to interrupt, João, we did a new CT scan, and we did a biopsy, although we don't have the images of the CT scan here, because it was also done outside. But I think João should speak about the biopsy.
Yes, I can show you.
Found.
I can show you the images of the tumor biopsy. We have this tumoral infiltration with these large cell with large nuclei. We find some mitosis here and here, for instance. And this tissue also stands for chromogranin A and synaptophysin, which are markers of neuroendocrine differentiation. And importantly, it has a very high proliferative index, meaning that it is a poorly differentiated lesion. So the final diagnosis is a large cell neuroendocrine carcinoma. This large cell neuroendocrine carcinoma was originally found in lung, but since then it has been described in several other extrapulmonary locations. But anyway, the main site of primary tumor is still in the lung. Not surprisingly, liver doesn't appear on this list since in the generality of neuroendocrine primary liver tumors, these tumors are very rare. There are only about 100 reported cases in literature of a primary neuroendocrine tumor in the liver. About the question of the production of alpha-fetoprotein, we only found these two reports of a large cell neuroendocrine carcinoma producing alpha-fetoprotein. We know that up to 40% of neuroendocrine tumors have some non-neuroendocrine component, but now we only have one sample, so we cannot prove that this is a pure large cell neuroendocrine carcinoma, or if it has another component that explain actually this alpha-fetoprotein production. So we assumed lung large cell neuroendocrine carcinoma, so we should know that it's a rare disease as well, accounting for about 3% of lung cancer. It has a very poor prognosis, and at diagnosis, we have 40% of cases with distant metastases. And to our best interest, we found that the survival time of a patient with liver metastases is 3 months. So we discussed the case again, and here we decided to perform another PET-CT scan and to begin systemic therapy. Unfortunately, the patient missed the oncology appointment and returned only in November to perform the PET-CT scan that showed no suspicion lesions beside this high uptake in the pancreatic head with a very suspicious SUV of 20. I'd like to remember, as these authors point out, that although most patients present low uptake in the pancreatic head, a high focal uptake in the uncinate process mimicking a malignant tumor can be physiological with a maximum reported SUV up to 28.7. So we decided to repeat the CT scan. Here we have appearance. The right suprahepatic vein is not pushed anymore. The right portal vein doesn't have that involving bulging, and we only have this. Well, the liver is not as engorged as before. We have here the images in parallel, and we can see the difference.
The connection is not very good, João.
Yeah. But we don't have
What João is showing is in fact a regression of the images that we saw, not so much in the liver because the images were not very good in the liver. But can you go ahead, João?
Yes.
The mediastinal.
Do you remember this mediastinal mass? We have here the comparison. This 3 centimeter large now presents like this, like a adenopathy with no suspicions adenopathy. And here we have the CT scan. You remember this lesion, 2.5 centimeter lesion in the upper right lobe, it has gone. In parallel, the alpha-fetoprotein returned back to normal, and the CA19.9 also decreased to normal. We repeated the liver biopsy, and it only showed liver cirrhosis with mild activity and without evidence of neoplasia.
So what we wanted to show you here was a rare case of probably metastatic clear cell neuroendocrine tumor, alpha-fetoprotein expressing, that had in fact a spontaneous regression with any kind of therapy.
Exactly, a massive spontaneous regression, which is extremely rare. Its estimated incidence is of less than 1 per 100,000 cases, and is actually most often noticed in but for large cell there are only 4 cases reported.
We cannot hear you, Jean.
Can you hear me now?
A little better, but not really.
So I was saying that there are only 4 cases reported of a spontaneous regression for large cell neuroendocrine carcinoma. And we repeated the CT scan in May, and the regression is maintained. And now we keep this patient vigilant.
Okay, I don't know if you have some experience or some similar cases.
It's good that he missed the appointment with oncology.
Yes, in fact.
Inus.
It's called a miracle.
Yes, I think so, yes.
I don't know if John is ready or not.
Sorry?
Unfortunately, Hugo, I don't think Bobby can fix the issue. Something to do with Google Meet. We can't seem to get it to present. I'm sorry about that.
Yeah, but cannot he send you your...
Yeah, you tried it.
Can you hear me now?
Yeah, we can hear you now, Bobby. Maybe
hear you.
Can you hear me now?
Try.
Yes.
Okay, give it a
So,
try.
Jean, you have to leave and let Bobby in.
Of course, thank you.
Apologies, and I hope it works this time.
I think we have to shut down the micros.
Something is echoing.
Can you try to share, Bobby?
Stop your microphones.
We have to stop the microphones.
Bobby is here.
I think this conference is held in Paris.
This time it's not letting me share the slides. Really sorry about it. Maybe we'll have to do it again, as John was saying.
Yeah, it does. It looks like you cannot
Really
share.
sorry about it.
It is worse than me.
I think a little bit worse. Yeah, sorry. It's not promising, Bobby.
No, we are waiting another miracle, I think. You cannot speak.
It was a very interesting case. I could tell from the preview.
The previous one? Yes.
No, the preview that we
yeah,
saw
the previous
part of
one,
it.
yes.
No,
miracle, but you know, miracle exists.
Okay, whatever.
Miracle exists.
No, I'm talking about John's case. John's case. The complexity.
Unfortunately, they are very rare. But
cystic lesions are always interesting. Cystic lesions are difficult.
Okay. I think that we will probably have to try for the next staff. I doubt we're going to succeed today. I'm sorry about that.
You go?
Yes, I think this is the last case that we have to present today.
Okay.
Is there a registry of miracle in medicine?
Not sure.
Try to find, open one.
Spontaneous regression of.
But you know, sometimes miracle need a little time. You know, in church they wait some centuries before accepting a miracle. So it's a long follow-up for you.
I think there are some cases of spontaneous regression of hepatocellular carcinoma.
Yes.
A lot of. But
HCC regression there is.
Not that size and not that type of histology, because it was a very aggressive one. So it's really a miracle.
There's a publication, I'll try to find it and send it to you, about spontaneous regression of HCC.
We've seen also in HCC, yes.
Yeah.
But this was not HCC.
No, maybe it is mixed.
And this was of 60% or whatever.
67 KI.
I would say this is probably a mixed tumor.
Yes, mixed tumor, I think.
No.
But anyway, it was very serious.
We cannot rule out that the person drank anything or something, but I don't know.
Is he from Lisbon?
Don't you go? We have no other cases?
We have no other cases, Professor.
Okay, so that means we're finished now. It is time. So it was said it is the last stuff of, let I say, this 6 months period, university period. So the next stuff will be in September. So we are, I think, September, October, November, not end of December, of course. That means we have 3 staff meetings for this year, prepare the cases, and I wish you a good vacation.
Bye-bye.
Bye-bye.
Bye-bye all.
And next
Bye-bye.
time, I have a better internet. Mark, I call you after. Stay online. Don't buy telephone. Thank you.
Thank you very much. Bye-bye.
Thank you for the meeting. Bye-bye. Bye-bye.